So we're going to start now talking about specific agents used in the treatment for bipolar disorder. So the first agent we're going to talk about is lithium. Lithium is arguably the gold standard of bipolar disorder treatment. It's an oldie but goodie. It actually first started being used in the 1800s as a medicinal treatment for gout, neurological ailments, GI ailments, as well as a table salt substitute. Here I have a picture showing that we used to have lithiated lemon soda by 7-Up. So really, again, an oldie but goodie. In 1949, Cade described its successful treatment of mania. Then by 1970, the FDA approved it for the treatment of acute mania. In 1974, it was approved for prophylaxis of bipolar disorder. More so, the prophylaxis of inducing, depression or mania. In terms of its mechanism of action, it's not completely known. Inositol monophosphate depletion results in reduced amounts of catecholamines via second messenger inhibition is one theorized mechanism. We also see that lithium increases and stabilizes glutamate uptake. Remember, glutamate is our main excitatory neurotransmitter. We see it also enhances serotonin and norepinephrine function in the CNS. So it does seem to potentially explain some of the theories of the pathophysiology of bipolar disorder. In terms of indications and formulations, I'm less concerned with you guys knowing the pure FDA indication. Really, it's an agent that we can use for mania as well as for maintenance treatment. Remember, going back to that one graph, lithium works for both bipolar depression and bipolar mania. In terms of formulations, we do have several different forms. We have an immediate release and extended release form. We also have an oral solution, lithium citrate. So 300 milligrams of lithium carbonate is equivalent to 8 milliequivalents of lithium citrate. So do note here in the table what doses are available for lithium. Now, in terms of starting lithium, for adults, we typically start with 300 milligrams twice a day. In general, most patients will need at least 900 milligrams per day. We usually see between 900 to 2400 milligrams per day in 2 to 4 divided doses, and we do generally prefer it given with meals to help decrease some stomach upset. In our elderly patients, we can still use lithium, but we'll talk about how lithium is eliminated. And in elderly patients, the route of elimination is typically decreased. So in the elderly, generally 300 to 600 milligrams total per day is what they need, with the usual dosage range being anywhere from 300 to 1200 milligrams per day. In our adolescents, from 12 to 18 years old, we can start lithium at 25 milligrams per kilogram per day, again, still in 2 to 3 divided doses, with the target dose being around the 30 milligrams per kilogram per day. So, as I mentioned, our elderly tend to need lower doses of lithium, and that is because it is 100% renally cleared. So in hepatic impairment, there's no dose adjustment because lithium is 100% renally cleared. Now, this does not mean that we can't use it in individuals with renal dysfunction. We just have to adjust the dose. So we can still use lithium when there's renal impairment. We just have to adjust the dose. So creatinine clearance between 10 to 50 milligrams per minute, we want to administer about 50 to 75% of the normal dose. Creatinine clearance less than 10, administer between 25 to 50% of the normal dose. And in those who are on hemodialysis, we want to dose it after dialysis. So again, 100% renally cleared. These little blobs are very important blobs. In terms of pregnancy category, lithium, when we talk about categories, lithium is a pregnancy category D, and it is D due to what's called Ebstein's anomaly, which are cardiac malformations during the first trimester. And again, about 50% of pregnancies are unplanned, in the first trimester being when people are finding out that they're first pregnant, again, that would be when there could be a chance for risk with lithium exposure. Additionally, lithium is excreted in breast milk. So again, caution with use, but with the pregnancy category D, when we talk about categories, D is really where there is risk, we're aware of risk, but still benefit may outweigh the risk. Once again, important blob, lithium is 100% renally cleared. Again, lithium is 100% renally cleared. There is a slow distribution across the blood-brain barrier. It's absorbed rather rapidly, with complete absorption between 6 to 8 hours after the dose. And the bioavailability is not affected by food, which is why, again, we do tend to recommend lithium being given with meals. Doesn't affect the bioavailability, but it helps to decrease side effects. Half-life is about 24 hours, and up to 36 hours are in our elderly patients or in patients with renal impairment. Again, lithium is 100% renally cleared and excreted in its pure form in the urine. It follows first-order kinetics, which means that in general, to double the lithium level, and we'll talk about lithium level, we generally tend to double the dose. Half-life, so it generally takes 5 times the half-life to reach steady state. So that means that we generally will check a lithium level 5 days after starting the lithium. Now, another key is the onset of action. So it's absorbed quickly, but the onset for mania generally takes between 7 to 10 days to reach the therapeutic effect once we're at a therapeutic level. Again, it takes at least 5 days to sometimes get to a therapeutic level, so between a week to week and a half is how long it might take to help treat mania. Given that patients in a manic state might be hospitalized during that time, that's a long time for this medication to kind of kick in. When we talk about depression, generally looking at greater than about 1 month of therapy may be required. So again, still taking a longer period of time. Lithium's treatment for depression in terms of how long it takes is similar to our conventional antidepressants. So we really want to optimize efficacy as well as prevent toxicity. So this is my little green blob, so very important. Yes, you need to know this. You need to know everything, but the green blobs are where really important. So we do have levels that we check. And we use lithium primarily these days for bipolar disorder. So what we find is that for acute mania treatment, we need a lithium level between 0.8 to 1.5 milliequivalents per liter. And then a maintenance phase, we generally need a little bit lower, so 0.6 to 1.2 milliequivalents per liter. You'll obtain the plasma levels 12 hours post-dose. And again, ideally you want to do it once it's at steady state. So after about 5 days from when you start the medication, because steady state is achieved generally 5 times the half-life. With managing levels, lithium again follows those first order kinetics. So remember back to PK, first order kinetics are kind of nice. Pretty much when you change lithium dose, it's expected to change that way with the steady state concentration. So a doubling of a lithium dose, you would expect the level to also double. So let's do an example here. A healthy adult is taking 600 milligrams of lithium daily with a steady state concentration of 0.4 milliequivalents per liter. First off, is that therapeutic or not? So we're going to say that this would not be therapeutic level because therapeutic is, going back, 0.6 to 1.2 milliequivalents per liter on the lower end and 0.8 to 1.4 milliequivalents on the higher end. So we've learned that the level is a bit too low. So what do you expect to happen if you increase the dose from 600 milligrams daily to 600 milligrams twice a day? So if you double the dose. You should expect to see the level also double. So again, first order kinetics. and 0.8 is right in the dosage range for both acute treatment as well as maintenance. So, lithium side effects. Unfortunately, even though this is our gold standard, a lot of times patients may not tolerate it well because there are a lot, and this is not an all-inclusive list. So nausea, vomiting, diarrhea, again, wanting to dose with meals, an intentional hand tremor, increased thirst, and increased urination. We see weight gain, cognitive problems, more of a cognitive slowing, lethargy, dermatologic problems. So really, we can see acne, psoriasis develop, alopecia. Also leukocytosis, elevated white blood cells, hypothyroidism, as well as cardiac effects. So bradycardia and AV block. So in terms of managing the side effects, again, this is a really effective agent, and we see that it works well. So we might want to keep it on board despite the side effects. Rather, maybe want to try to manage those side effects. So again, GI upset, recommend take with food. You can change the dosage form away from the immediate release to the sustained release, and also try to divide the dose so there's less of a lower dose being provided. An intentional hand tremor, what you can do is again divide the dose so that less is being released at the same time, changing to the sustained release product, as well as potentially adding a beta blocker, propranolol. So, just to refresh, where else did we see propranolol being used within our psychiatry module so far? So, we should have seen propranolol. We should recall it was a treatment within social anxiety disorder to help prevent the physiological symptoms of anxiety when there is more of a performance-related effect. But we can also see it used for, again, the treatment of a hand tremor. And again, it would be dosed at a lower dose than what would be given for blood pressure. Polydipsia and polyuria, so increased thirst and increased urination. Ideally avoiding dehydration. Because this can be a side effect, we want to make sure that patients do not become dehydrated. We can lower the dose as well as try to consolidate the dose to bedtime, because during bedtime patients will be sleeping and then not waking up, not drinking more, and therefore not urinating more. Sometimes we can also see a amiloride be added, but that would be kind of last resort. For weight gain, unfortunately, there's not too much that we can do here outside of kind of our standard weight management strategies, which would be increase exercise and monitor diet. For lethargy, that fatigue that can develop, we want to tend to consolidate the dose to bedtime. So in general, we see lithium dosed twice a day. What we might do is dose 300 in the morning, maybe 600 at bedtime, trying to give more the dose at bedtime when patients would be wanting to sleep. For the dermatologic problems, again, not too much in the way of prevention, it's more just using conventional dermatologic treatment there. Leukocytosis, we actually continue treatment with the elevated white blood count, and it's not a harmful elevation in white blood count, but given that white blood count is also elevated with infection, we do want to just make sure that if there is an elevated white blood count, is it just associated with the lithium, or does this patient have an infection? Also, hypothyroidism. So we are actually going to be checking the thyroid when we're checking lithium levels and other aspects. So we would continue the treatment, but add thyroid supplementation. Okay, so with hypothyroidism, if this develops, we still keep lithium on board and just treat the hypothyroidism. For the cardiac effects, the recommendation will be to monitor the EKG, heart rate, as well as electrolytes, making sure that electrolytes are good at good levels to prevent any further cardiac complications. So, in terms of lithium monitoring, again, just to highlight, check the lithium level after reaching steady state, so approximately 5 days. We want a trough level, so about 12 hours after the last dose or immediately prior to the next dose. You want to check about twice weekly until the level and the clinical status are stable. And then repeat every 1 to 3 months or as clinically indicated. We want to know once a patient starts doing well, what is their lithium level that helped them get to a good maintenance. In terms of other labs, baseline labs, we want to check renal function, electrolytes, thyroid, CBC with differential. We want to check a pregnancy test because remember, lithium does have some risk when used in a pregnant patient. It is a pregnancy category D. And then in patients who are over the age of 40, we want to check an EKG, see how their heart is at baseline, as well as get a weight. Then, once we've started lithium, we want to check renal function every 2 to 3 months for the first 6 months, and then about every half a year to every year, or as clinically indicated thereafter. In terms of thyroid profile, we want to check about 1 to 2 times in the first 6 months, then every 6 to 12 months thereafter. And remember, if the thyroid function does get to the point where we see hypothyroid, we continue treatment and rather manage hypothyroidism. Similarly, if we see that renal function becomes impaired, we tend to continue lithium and just dose adjust. So these are two conditions in which it is not a contraindication. We can continue lithium and make adjustments accordingly. So there are some things that can actually increase a lithium level as well as decrease a lithium level. So again, these are not contraindications, but we are going to want to dose adjust lithium in the presence of these agents. So one way to remember these is a little acronym called no ACE in the hole. So NSAIDs tend to increase the lithium level by about 25%. Of note, Sulindac and aspirin are considered the safest NSAIDs to use in patients on lithium as they have minimal impact on the lithium level. I have only seen Sulindac used occasionally, and it has only ever been used when I've seen it in patients who are taking lithium. Aspirin, again, similar. So aspirin for pain relief, remember the dose is much higher than that for, cardiovascular prevention. Also, ACE inhibitors, we see about 25% increase in the lithium level. Again, that does not mean that we stop lithium or we stop an ACE inhibitor. Rather, we dose adjust the lithium accordingly. Hydrochlorothiazide increases the level by about 50%. So this is our thiazide diuretics. And what happens is we see the body kind of confuse lithium and sodium. So the hydrochlorothiazide leads to increased reabsorption of lithium and sodium, and therefore the body holds on to these two cations, leading to then that increased level. Excess sweating and then low sodium intake. So again, the body will tend to kind of confuse lithium and sodium. If you guys remember your periodic table, go back, take a look at it. You'll see the two of these to be very close to one another. So when we are sweating, we tend to lose sodium. So the body wants to hold on to sodium as much as it can, but it doesn't have sodium really, so it has the lithium that it'll hold on to, therefore increasing the lithium level. Also, when we're not taking a lot of sodium intake, the body again wants the sodium, so it's going to confuse the sodium and then reabsorb lithium in its place. So these are all ways in which how we can get an increased lithium level. Other causes of decreased lithium levels. Decrease would be one, poor compliance, poor medication adherence, and very commonly in bipolar disorder, there's a lot of medication non-adherence, medication non-compliance, because really with the two stages, with mania and then also with depression, patients specifically that have had a manic phase or are in a manic phase, it's such a favorable phase that they're not going to want to take medications that bring that phase down. They feel on top of the world. And so therefore, we'll start to see patients that aren't going to take their medications. Also, because of all the side effects, patients are not going to feel like, oh, I don't really need this. So that's one possible cause of why a lithium level would be decreased. more of an obvious one. Additionally, caffeine. So excessive caffeine intake, we can see decreased lithium levels. Again, it's not going to be recommended to have a patient who drinks 3 cups of coffee to stop drinking coffee. Rather, we want to know if they're making any changes to their caffeine intake, because then that would impact their lithium level. Theophylline, increased sodium intake. So again, the body is going to confuse sodium and lithium. So with increased sodium intake, the body is actually going to want to get rid of that extra sodium, but instead it's actually going to start getting rid of the extra lithium. In pregnancy, we actually see decreased lithium levels, as well as with potassium-sparing diuretics. So these are all some potential causes of decreased lithium levels. Now, as I mentioned, we want to balance efficacy against toxicity. So we want to prevent lithium toxicity. So we do have a black box warning for lithium, which really details the need to monitor. In early toxicity, levels that are above 1.5 milliequivalents per liter, we start to see a marked tremor. So not a mild tremor, but marked. Nausea, diarrhea, blurred vision, vertigo, confusion, as well as increased tendon reflexes. In worsening in toxicity, greater than 2.5 milliequivalents per liter, the worsening of previous symptoms, so worsening tremor, nausea, diarrhea, vertigo, confusion, as well as additional neurological complications. So patients can develop seizures, they can go into a coma, as well as cardiac dysrhythmia. And levels greater than 3.5 milliequivalents per liter are potentially lethal. So again, lithium can be lethal, and again, if taken in an overdose setting, this could be an agent that could be lethal to the patient. Now, if we get to the patient, if we're checking levels and we see that there is lithium toxicity in place, the first thing will be to hold any further doses, identify any potential causes. Was this a suicide attempt that somebody took all the lithium that they have? Was there some change that happened that led to an increase in their lithium level? Was there a medication change? What we would do is then administer IV saline and manage their electrolytes. If it's early, we want to minimize any additional absorption. So if this patient comes in very soon after, we're starting to see the signs of lithium toxicity and they've recently taken it, the two things could be a gastric lavage and induced emesis. And again, lithium is 100% renally eliminated. So we could use emergent hemodialysis, and this would be indicated if the plasma levels are greater than 6 to 8 milliequivalents per liter. And we would want to decrease the lithium level over time. And that would be one kind of the most extreme approach, but emergent hemodialysis will clear the lithium out of the system. I won't play this video for you guys. However, when you get to the slides, I highly encourage you to play this video that just details a little bit about lithium. So, in terms of clinical pearls, lithium is deemed the gold standard for bipolar treatment, 100% renally cleared. We do see drug-drug interactions. Do note which agents can lead to increased lithium levels, what things can lead to decreased levels. It is pregnancy category D due to cardiac malformations. Lithium follows first order kinetics, so doubling the dose should double the level. Likewise, halving the dose should half the level. It does have a slower onset of effect. So remember, for its treatment of depression, it generally will take about a month. For its treatment of mania, it will generally take between 7 to 10 days. And again, in an inpatient setting for an acute hospitalization, that is going to be a long time to stay hospitalized. Another thing is that lithium actually reduces suicidality. So there are 2 agents within this course that we will talk about that actually inherently reduce suicidality. Lithium being one, and the other one being clozapine, which is an atypical antipsychotic that you'll learn about when we get to schizophrenia. So that concludes lithium. Now we're going to move on to valproic acid, also known as divalproic sodium. So, mechanism of action, and we're going to see this agent come back several times. We're going to see it for migraine, we're going to see it for epilepsy. But mechanism, so there's many proposed mechanisms of action. Valproic acid is inherently an anti-epileptic drug. So it increases GABA levels in the plasma and CNS, so increases our inhibitory neurotransmitters. It inhibits GABA catabolism, again, leading to increased GABA levels, prevents GABA reuptake, increasing GABA, enhances the effect at GABA at the GABA A receptor, helps to normalize sodium and calcium channels, can help to decrease action potentials. It regulates downstream signal transduction cascades, and it has anti-kindling properties that helps to decrease rapid cycling and mixed states. So it can help to decrease further mood states within bipolar disorder. In terms of indications, again, I'm less focused on the pure FDA indications. However, it is approved for the treatment of acute mania or mixed episodes with or without psychotic features. Again, other indications where we're going to see it again is with seizures and migraine prophylaxis. So, as you can guess, valproic acid will come back again in neurology. In terms of our formulations, we have many different formulations. We have an IV formulation. We also have divalproic sodium and then valproic acid. So when it comes to the divalproic sodium, we have Depakote delayed release, extended release in sprinkles. With valproic acid, we have a Depakine syrup, capsule, and then soft gel. So we do have a solution form for some patients, as well as many oral forms. The fastest time to absorption is kind of where we see differences. So the valproic acid sodium will be faster, more quickly absorbed than the capsule, which will be more quickly than the sprinkle, which will be about equal to the delayed release, and the delayed release would be more quickly absorbed than the extended release, which should be what you would expect. Now, how are we going to dose valproic acid in bipolar disorder? So, a loading dose can be given, especially for patients that we're seeing that require acute treatment. And again, valproic acid is going to provide much better treatment and coverage for mania, a little bit for depression, but much better for mania. So in young, healthy patients, we're going to do 20 milligrams per kilogram per day. We may give up to 30 milligrams per kilogram per day for the first 2 days and then reduce down to 20 milligrams per kilogram per day. So one shortcut is to take the patient's weight in pounds and then add a 0 to the end. That's a shortcut to see what would be their loading dose. A lot of people try to dose valproic acid conservatively, but in patients that require acute treatment for mania, we want to do the loading dose. And then the maximum, there's a huge range. The maximum dose of valproic acid would be 60 milligrams per kilogram per day. So really in comparison, the 20 milligram per kilogram per day loading dose is not very close to then what the max would be. In patients that are elderly or have organic brain damage from trauma or other substances, we will do a slower titration. So we'll start more conservatively with 250 milligrams twice a day or 3 times a day, and then increase that by about 250 to 500 about every 3 to 7 days. In general, we see that patients tend to require between 750 to 4,000 milligrams per day. Typically, the most effective doses will be within the 1,000 to 2,000 milligram per day mark. I very rarely have patients that are going to respond to just 500 milligrams of valproic acid. I generally know that they'll need higher doses than that. Pregnancy category. So again, I do still go back to the pregnancy categories. I know that they've not been using the category as much, but more so giving you the evidence for its lactation and pregnancy risk. But I think the categories are just a little bit easier for learning purposes. So with bipolar disorder, valproic acid is pregnancy category D. In migraine prophylaxis and prevention, it's going to be category X because the risk versus benefit. Is bipolar disorder potentially lethal? The answer is yes. because we have risk for suicide, and then in mania, we can have some really problematic behaviors. Migraine, on the other side, would not be a lethal diagnosis. So in some cases, you could use valproic acid in individuals who are pregnant. Highly recommend against starting the agent in our individuals who are young and childbearing age because of the neural tube defects that can occur. And neural tube defects tend to occur within the first month or so of pregnancy. And again, 50% of pregnancies are unplanned, and individuals don't typically know they're pregnant until at least about the 1 month mark. It's also excreted in breast milk, about 1 to 10% of the maternal concentration. So what our recommendation here is to use caution. But again, congenital malformations, the neural tube defects, is really going to be where our risk is in pregnancy. In terms of its pharmacokinetics, valproic acid is rapid and completely absorbed with bioavailability nearly 100%. It is highly protein bound, about 90%. So when protein binding decreases as the concentration increases. We see that valproic acid is primarily metabolized by the liver via glucuronide conjugation, so there's minimal CYP enzyme. So remember, when we talked about benzodiazepines, we have 3 that go through glucuronidation. Those are our locked benzos: lorazepam, oxazepam, and temazepam. Valproic acid also goes to glucuronidation. Half-life, we go anywhere from 6 to 16 hours. Here we're going to see steady state be achieved within about 2 to 3 days. So it's going to kick in much faster than lithium. Now, we're going to talk about valproic acid serum levels. So with lithium, that's an agent that we're using for bipolar disorder. Similarly, valproic acid is another agent we use for bipolar disorder. But remember, valproic acid has some other places in therapy. So valproic acid therapeutic blood levels were actually developed in terms of its use for seizures and not for bipolar disorder. So the therapeutic level for seizures is 50 to 125 micrograms per ml, and that's a trough level. In individuals with bipolar disorder, we generally need patients to get to at least a level of 50 or more. Any levels greater than 125, we tend to see an increased risk of side effects, and then we can see toxicity at levels greater than 200 micrograms per ml. So again, the therapeutic levels are truly based on seizure treatment and not bipolar. So really what I recommend is getting a level once a patient has reached what seems to be effective for their disease, and then checking the level to see what level they respond at, as well as checking levels to make sure we're not at a toxic level. So, black box warnings, again, big. Lithium had 1, the need to monitor. Valproic acid has 4, okay? So, valproic acid can cause hepatotoxicity. It can cause rare but life-threatening pancreatitis. Then again, pregnancy, the risk with pregnancy, we really do, if we're able to, not start this agent in young females or females that are planning to become pregnant, as well as patients with mitochondrial disease. So these are our 4 black box warnings that valproic acid has. In terms of adverse effects, again, it's not an all-inclusive list, but we do see that this agent can also have tolerability issues. Again, GI distress, nausea, vomiting, diarrhea, hair loss. So we see alopecia is possible with valproic acid as well as with lithium. It can cause headache, but again, it's always tricky because this is an agent that we do use to try to prevent migraines. So really we're talking about a headache, not a migraine. Dizziness, drowsiness, somnolence. Again, this is an anti-epileptic drug, and in general, they're kind of slowing things down. So we expect to see the sedation that comes. Thrombocytopenia. So it is going to be recommended to check CBC and look at platelets. We can see tremor and weakness develop. Cognitive dulling. So individuals kind of are slowed down. We can also see that increased appetite and weight gain. Again, lithium also had the possibility for weight gain. A benign LFT elevation, so an LFT elevation that is not harmful, not indicative, but we also have the rare but serious hepatotoxicity that can develop, which was one of the black box warnings. Hyperammonemia, so elevated ammonia, and SJS is Stevens-Johnson syndrome. This is, again, not an all-inclusive list. So let's talk about our monitoring. So we will be wanting to check Valproic level. So again, it's going to be a trough level, so ideally before taking the first dose of the day. We're going to want to check CBCs at baseline and then every 6 months. Again, for thrombocytopenia, LFTs again at baseline and every 6 months. Pregnancy test at baseline and as indicated. And again, pregnancy test only going to be for female patients. That should be pretty obvious, but again, pregnancy test only female patients. Ammonia, only checking ammonia when it's clinically indicated. So in GI, you guys probably talked about, elevated ammonia being a complication of liver disease. And when we have elevated ammonia, it can lead to really confusion and altered mental state. So if we have patients on Depakote who start to seem confused, that's really when we recommend checking the ammonia. We have some significant drug-drug interactions. So with lamotrigine and valproic acid, the area under the curve will be increased twofold in the presence of valproic acid. We're going to talk about how to dose the two agents together. Phenytoin, this one is a complex interaction. So initially it could decrease total phenytoin levels, and then phenytoin mode may double valproic acid clearance. So this one is going to be, you're going to just need to monitor both agents. Warfarin, valproic acid, very protein bound, will displace warfarin from albumin. So again, it doesn't mean you can't use these agents together, but you're just going to want to check the INR more frequently if valproic acid is added on board, or the reverse, warfarin gets added on board. So these are our three key drug-drug interactions. Clinical pearls for valproic acid, again, a faster onset of action than lithium. It's a preferred agent for mixed episodes, which is one of the specifiers for bipolar disorder, which we didn't talk about. We're going to want to avoid use in patients with hepatic disease because of the impact and the risk for hepatotoxicity. Pregnancy category D due to congenital abnormalities, and we have a loading dose strategy. So typically starting with 20 milligrams per kilogram per day.